So we will be taking some important clinical questions from medicine which has been repeated or which has been asked in the previous few years. Right now, these questions have been compiled from the important topics, and I hope you will like this session. So starting the session with very first question, and it goes like this: a 60 years old male, a case of rheumatic heart disease, presents with shortness of breath. On examination, hyperdynamic precordium is noted. Water hammer pulse was felt. Pistol shot gun sound is heard over femoral arteries. Now, what is the predominant valvular lesion which is associated with this presentation? Now here, what we need to do, firstly we will write the keywords, right? So let us see what keywords are given to us in the question. First is a known case of rheumatic heart disease. This is the first thing, right? Now second is hyperdynamic precordium. Okay, this is one. Then water hammer pulse. Water hammer pulse. Then pistol shot gun sound over femoral arteries. Right? So these are the important clues which are given to us. Now, out of this, the most classical and the one which should give you the answer is water hammer pulse. So let us take this word, water hammer pulse. This is also known as Corrigan's pulse. Now what happens here? It's a high amplitude pulse in which the pulse wave will come like this. It will strike the examining finger and it will disappear quickly. Right? So this is a high volume pulse where the pulse waveform will come and it will strike the examining finger with a force and it will disappear quickly. So comes and disappears quickly, and this is very classical for aortic regurgitation. Clear? So this is very classical for aortic regurgitation. So out of this all, if you know only this clue, you can reach up to your answer, that is aortic regurgitation. Now another keyword given is hyperdynamic precordium. Right? So what is written here? Precordium. Now what is this term precordium? Pre means before, cordium is related to heart. So this is the area over apex. So this is the skin area over apex. So if it is hyperdynamic, it means there is left ventricular over activity, and we know that there is backflow of blood in aortic regurgitation from aorta back to left ventricle. So left ventricle is overloaded. So that is hyperdynamic precordium. Then again this pistol shot, this is one more classical word, although very less frequently asked in exams. So pistol shot, this is also indicative of aortic regurgitation, and this particular sign is known as Troby's sign. Right? So there are many clinical signs in aortic regurgitation, but this one is known as Troby's sign. Right? So a classical presentation of aortic regurgitation. And here you should remember one more thing, that high pulse pressure. In some questions you also will get this word, high pulse pressure. Now what is pulse pressure? Pulse pressure is the difference of systolic minus diastolic. Right? So in aortic regurgitation, pulse pressure will be high, that is the difference between the systolic and the diastolic will be more than 40 millimeter of mercury. right? So these are few important keywords which you should know for aortic regurgitation. So very easy to diagnose, and the classical is water hammer pulse or pistol shot gun sounds over femoral arteries, right? And the third one, which is very frequently asked, although not a component of this particular question stem, is high pulse pressure. So the moment you have these three keywords, think of aortic regurgitation. So this is how you need to reach up to your answer. Okay, so this is classical of aortic regurgitation. Then moving forward to another question. Now here, which of the following is true regarding first degree AV block, atrioventricular block? First degree AV block. Now what happens in first degree AV block? All impulses, they travel from atrium to ventricle, right? So they travel from atria to ventricle. This is one first important thing which you should know. The term is block, but it doesn't mean that any of the impulse which is generating from the atria is not reaching up to ventricle. So all impulses, they reach up to ventricle. This is important fact which you should know. Now then you will ask, then what is the problem? If every impulse is going, then what is the problem? The problem is that there is delay. Clear? So the problem is there is delay in transmission of those impulses from atria to ventricle, and that is what is known as first degree atrioventricular block. So there is delay in the transmission of impulses from atria to ventricle, and on ECG, what is that parameter which tells us about the duration of the transmission of impulses from atrium to ventricle? That is PR interval. So what is that? That is PR interval. And therefore, what you will see on ECG, there will be prolongation of PR interval, right? So in first degree AV block, you have to say that the PR interval is prolonged, but since all the atrial impulses are going up to the ventricle, so heart rate will remain normal, right? So if we write this, heart rate is, or the R to R distance will remain normal. So what we will write? Prolonged PR but normal RR interval. Okay, so that's very important to understand. So here the PR interval prolonged, and this will be more than 0.2 seconds, right? So this is first degree AV block. The classical finding which you will say is PR interval prolongation. And why it is prolonged? Because the impulses which are traveling from the atrium to the ventricle are taking a little longer time to reach up to ventricle. So this is the classical clue, is prolongation of PR interval. And the second point which you should know, that all impulses which are traveling from the atrium will reach up to ventricle. So there will be no, it means every P wave will be followed by a QRS complex, right? So all P waves, because we know that P wave are because of atrial depolarization and QRS complex because of ventricular depolarization. So it means after every atrial depolarization there is a ventricular depolarization, right? So there is no skip. So all impulses will travel from atria to ventricle, number one, but the time which is taking for traveling from atria to ventricle will increase. So that's the classical for first degree AV block. Okay, that's very important. So because what student, they usually think that if there is a block, it means some of the impulses which are generating from the atria will not reach up to ventricles. But for first degree, that's not true. So that's the only catch in this kind of question. Okay, so please remember. The next question. A female patient presents with progressive worsening of dyspnea. On examination, there is a left parasternal heave and palpable liver. On auscultation, a systolic murmur is heard. Investigation reveals right axis deviation of heart. What is the most likely diagnosis? So again, the first thing which we need to do is to write the keywords. So firstly, we will write the keywords. Number one, there is progressive worsening of dyspnea, means breathlessness. So the breathlessness is increasing day by day. Then second is left parasternal heave. Left parasternal heave. Third is palpable liver. Fourth is a systolic murmur. And fifth is right axis deviation of heart. Now these are the clues which are given to us, and now based on this we have to reach a diagnosis. Now let us try to understand what is being given in the clues. First and the important clue, which is very helpful for a student, or in fact I would say the very first clue which should give you a basic concept of basic idea of the answer, is palpable liver. Now palpable liver, or sometimes it is called pulsatile liver, and this is classically in terms of valvular lesions, this is related to tricuspid regurgitation, right? So TR. Now you will say, sir, there is no TR in the option, so now what we should do? Okay, no problem. We can think of some right ventricular hypertrophy kind of condition, right? So there is right ventricular hypertrophy which has secondarily caused tricuspid regurgitation. So just take the right side of heart, something like this. So this is obviously the tricuspid valve, and here we have the pulmonary valve. Okay, so what is happening? The right ventricle is hypertrophied, right? This is right ventricle, this is right atrium. So what is happening? The right ventricle is hypertrophied, and because of this hypertrophy, the tricuspid valve is not closing properly, and it is resulting in tricuspid regurgitation. So although there is no pathology of tricuspid valve as such, but just because of the right ventricular hypertrophy, there is secondarily functional derangement of the functioning of tricuspid valve, and that has resulted in tricuspid regurgitation. So one of the keyword which we have reached up to now is right ventricular hypertrophy. Now the question is, how right ventricular hypertrophy will come? Now obviously, when the right ventricle has to contract against some pressure, then the musculature will get hypertrophied, and that pressure is in terms of pulmonary arterial hypertension, right? So what you will write here? Pulmonary arterial hypertension. So there is increased pressure in the pulmonary circulation, and to overcome or to push the blood into the pulmonary circulation, overcoming that high pressure zone, or you can say resistance, the right ventricular hypertrophy will occur. So, what is happening here? The main pathology is pulmonary hypertension, and just because of this there is right ventricular hypertrophy, and then it has resulted in tricuspid regurgitation. So, these are the series of events here. So, your answer will come out to be pulmonary hypertension. Now, you will say, sir, there are many more clues. Now, what to do? How to associate? So, this right ventricular hypertrophy is resulting in right axis deviation on ECG. This is also causing this left parasternal heave. So, left parasternal heave, right ventricular hypertrophy, right axis deviation, right ventricular hypertrophy. So, we have tackled this, we have answered this, we have answered this. Now, what is happening? Systolic murmur is left. How you will associate? Systolic murmur is because of tricuspid regurgitation. So, see, all the clinical points are now interrelated, and then you can finally reach up to the diagnosis of pulmonary hypertension. So, this is a slightly difficult question, I do agree with that, but yes, it needs a little bit of basic knowledge and you can reach up to the answer, right? So, it's slightly difficult, I would agree with that. So, this is how you can associate all the points, and the ultimate diagnosis will come out to be pulmonary hypertension. So, because of pulmonary hypertension, I will change the direction of the arrows. So, because of pulmonary hypertension, there is right ventricular hypertrophy, and because of right ventricular hypertrophy, there is tricuspid regurgitation, and this tricuspid regurgitation is leading to pulsatile liver. So, this is pulsatile liver, right? So, a very good question. Chalo, moving forward to next question. Again, from a very important topic. A patient had acute ascending bilaterally symmetrical lower limb flaccidity over a week, followed by upper limb weakness. There is a history of viral infection 2 weeks back. On examination, there is loss of spinal reflexes. What is the diagnosis? Now, again, we should write the keywords first. Now, what is given in the question? Ascending bilaterally symmetrical, then lower limb flaccidity. Okay, so I'll write flaccidity as a separate word. Flaccidity, right? And then later on there is upper limb weakness. So, lower limbs first, followed by upper limb. There is a past history of viral infection 2 weeks back, okay, and there is loss of spinal reflexes. So, these are the keywords which are given to us in the question. Now, the classical keyword which is needed to make a diagnosis here is ascending flaccid paralysis, right? So, this is ascending flaccid paralysis, and this is classical for one condition which is known as Guillain-Barré syndrome or GBS. These are the classical words for Guillain-Barré syndrome. Now, let us take this condition. Now, what happens? There is a past history of, so there will be a past history either of viral infection or diarrheal disease especially Campylobacter jejuni, right? So this is an usual association. Either there will be a past history of viral infection or diarrheal disease, especially Campylobacter. Now the presentation is very unique. Now what we are saying, ascending. Now what is this word ascending? What do you mean by the word ascending here? Ascending means, suppose if this is the lower limb, the paralysis will start from foot and it will go towards hip. So this is known as ascending. So it will start from the toes and it will go to the foot. So ascending, paralysis will go from foot to hip. That's ascending paralysis. So this is known as ascending paralysis. And one of the classical presentation is, patient will come to us and he will say that footwear slipping off the foot. So the patient will tell that whenever I am walking, my footwear, my sandal or my chappal, it will come off my foot. So that's one very important clue. So this is ascending paralysis. Now bilaterally symmetrical, it means it is involving both the lower limbs, almost same, and flaccidity. Now flaccidity means what? This is paralysis. Okay, so there is paralysis, and this is followed by upper limb weakness. So this is all classical for, so predominantly there is motor involvement, muscular involvement. So this is motor involvement. Very rarely there is any sensory involvement, less than 10% of cases, but mainly predominantly it is motor involvement, like skeletal muscle involvement. Now in CSF examination there is one term which you should know, and that is known as albuminocytological dissociation. So please remember this term, albuminocytological dissociation. The moment you have this word with you, always go for diagnosing the condition as Guillain-Barré syndrome, which is under acute inflammatory demyelinating polyneuropathy. Okay, so that's kept under which condition? Acute inflammatory demyelinating polyneuropathy, right? So that's very important. So this is all classical clues for diagnosing Guillain-Barré syndrome, and although not given in this particular question, but in many MCQs albuminocytological dissociation is always given, where the albumin levels are high but the cells are normal in CSF analysis. That's albuminocytological dissociation. This condition is self-limiting. So self-limiting, prognosis is good, recovery occurs. What we can do? We can do plasma pheresis, okay, or we can give IV immunoglobulin, IVIG. So this is in short, and this is enough for Guillain-Barré syndrome. Very easy to identify. Please don't do any sort of mistake in this particular topic. Okay, then moving forward to next question. A patient presented with fever, headache, mental confusion, nausea and neck stiffness. Lumbar puncture was performed and CSF analysis shows protein 45, glucose 7 and increased neutrophils. What is the most appropriate treatment? Now this kind of question stem you might have studied a lot before, and that was usually about making a diagnosis. So you could easily make a diagnosis here, I'm very sure. But what is the most appropriate treatment? So the examiner has gone a step beyond the usual presentation, and now they are asking you about the treatment. So I think most of you must have already made the diagnosis, but let us go with the protocol like keywords. Now what is happening here? Fever, headache, mental confusion, nausea, and neck stiffness. I have kept all these terms together because it suggests meningitis, right? So this is classical presentation that the patient is having meningitis. Now, but what is more important for us is CSF findings, and here what we will see that the proteins slightly increased, but importantly the glucose is markedly decreased, because glucose is normally 2/3 of the normal blood glucose. And third, what you can see here, increased neutrophils. So normally there should be no neutrophil, but here the neutrophils are very much high. So this all makes a diagnosis of acute bacterial meningitis, right? I think that all of you can make the diagnosis. So it's a bacterial meningitis. Now the question is about treatment. What you need to give? Now obviously we should include drug as a part of empirical therapy, which is controlling the bacteria which might cause this acute bacterial meningitis. So one should know what are the bacteria which can cause acute bacterial meningitis. So one is Streptococcus pneumoniae or pneumococcus, and the second is Neisseria meningitidis. Clear? So these are the two important bacteria, and to control them the best choice is going with ceftriaxone and vancomycin. Clear? So this is how you should approach this question, and therefore the answer will come out to be ceftriaxone and vancomycin as a part of empirical therapy, because we have to control both. Either it could be Streptococcus pneumoniae or it could be Neisseria meningitidis. So we have to give a combination of drug so that it covers the probable bacterial agents. Clear? So this is how you should solve this particular question. Then next question, a 17 years old has proteinuria of more than 4 gram per day. There is edema and hypoalbuminemia. What is the recommended management? So let us write the keywords first. Obviously one of the important keyword is 17 years old male. Then second is proteinuria 4 grams per day. Then hypoalbuminemia and edema. Now what is the treatment? So firstly we have to reach the diagnosis. Now here, because of protein leaking into the urine, there will be low serum albumin level, and because of low protein there will be edema. So these 3 points are interrelated. So here what we notice that there is proteinuria, means protein is going in urine. So it is lost in urine and the magnitude is 4 gram. Now this all classically, I think most of you can make the diagnosis. This is nephrotic syndrome. Clear? So this is nephrotic syndrome, right? So this is nephrotic syndrome. That's very important. Nephrotic syndrome, because there is proteinuria, there is hypoalbuminemia, and proteinuria, that is 4, because in nephrotic syndrome the definition is more than 3.5 gram per day proteinuria. That is what is included in the description of nephrotic syndrome. So here, because of loss of protein, the level of proteins in the body will decrease, and as a result of that, there will be generalized edema. So that's nephrotic syndrome. Now the question is about a 17 years old child. In 17 years old, the cause of nephrotic syndrome is minimal change disease. Clear? So going with that age group, we can say that this is probably a case of minimal chain disease, which is also known as lipoid nephrosis. And why we call it minimal chain disease? Because when you look in under normal microscope, there are no changes, and therefore it was named as nil disease, or right, so it is also known as nil disease. But later on, when it was viewed under electron microscope, what was seen? Fusion of foot processes. I think all of you must have read in pathology. So light microscopy, no changes, but in electron microscopy, we can see fusion of foot processes. And remember here one more thing, the glomerular is normal, right? So there is no glomerular damage. Now coming to the question, now what we need to give for this? The best management is steroids. So what we need to give? Steroids, and the result is wonderful, you can say. Dramatic improvement, right? So there is dramatic improvement. Fine. So this is how you will reach it up to your answer, that for this particular case, since it is a case of nephrotic syndrome, especially minimal chain disease, so we should start the patient on steroids. Okay. So a very important topic, nephrotic syndrome, minimal chain disease. Every year we have a question framed in one or other way, and very easy to diagnose also from the question stem. Clear? So this is what you should know about minimal change disease. The next question, a 62-year-old diabetic male presents with severe retroesternal chest pain for 6 hours. ECG shows ST segment elevation in leads 2, 3 and AVF. Thrombolysis performed. On day 3, that's very important, he develops sudden hypotension, raised JVP and muffled heart sounds and pulseless electrical activity. Most likely diagnosis. I think this is one of the best questions I have seen. Now let us write the keywords. What is written here? Severe retroesternal chest pain. The moment you have retro means behind, right? Retro means behind. Now the moment you have any question about, very good Priya, very good, we will get to that. So the moment you have any adult presenting with chest pain, the very first thing which comes to our mind is obviously myocardial infarction. Okay, that's the first thought which comes to our mind. Then ECG is showing ST segment elevation. ST segment elevation, and especially in leads C 2, 3, AVF. Now this is classical for inferior wall MI. Clear? Lead 2, 3 AVF, that's inferior wall MI. And yes, it is classically ST segment elevated MI. So one thing is clear, that the patient was having myocardial infarction. He was managed by thrombolysis, streptokinase and all, right? And then after 3 days, the real problem happened after 3 days. Now what has happened after 3 days? He developed sudden hypotension. Yes, the BP fall down suddenly. Then raised JVP, and then muffled heart sounds. And Priya was absolutely right. What has happened now? This is the classical backstride. Now what is this? This is the backstride and cardiac tamponade, right? So this is absolutely right. The patient has developed cardiac tamponade. Now the question is, in a case of myocardial infarction, why the patient will develop cardiac tamponade? Because cardiac tamponade is collection of, in particular to this case, there is some collection of some fluid or blood within the pericardial sac. So now the question is how that collection has occurred. So to answer that, what has happened, there is ventricular wall rupture. So what has happened? The ventricular wall has ruptured and the blood from the ventricle has gone into pericardial space, right? So the blood is in pericardial space. Clear? So that's how you will associate all the terms. So what has happened? There is ventricular wall rupture and this has secondarily resulted in cardiac tamponade. And this is very important, time, because ventricular wall rupture, it usually happens around 3 to 7 days of MI. So after 3 to 7 days of MI, there is high possibility of ventricular wall rupture and patient can all of a sudden can go into cardiac tamponade. And if you remember, just few days back, there was one sport person, Jaspal Rana. He died in a similar manner, right? He was having myocardial infarction. Although he was traveling, he was admitted to some Max hospital. He was revived, but as they were planning to discharge him, the ventricular wall ruptured. He went into cardiac tamponade and then he lost his life. So this is a very beautiful question, very beautifully framed, and depending on the option you can choose your answer. But the main thing which you need to remember here is the complication, that is ventricular wall rupture. Brahmi, very difficult to answer your question at this moment of time. Then moving forward to next question. A 32-year-old female presents with complaint of fatigue, paleness and dizziness. Laboratory investigations reveal an increased total iron binding capacity. Based on these findings, what else would you expect in this patient? Now, this is a hot favorite topic for the exam setters. Every year we see, every exam in fact, we see a case based question from this topic. Very good, Priya, you are absolutely right. Yes, so let us write the keywords first. So the patient is having okay, so the patient is having fatigue, paleness and dizziness. The moment you find this word paleness, think of anemia, right? So think of anemia. Now what is happening here? Another classical clue word is given: total iron binding capacity is increased, right? So it means the transferrin is less saturated. Transferrin is less saturated, and transferrin is the transport protein for iron. So it means iron is less in the body. That's why the transferrin is less saturated, and therefore the total iron binding capacity is increased. And less iron in the body is what? Iron deficiency anemia. Clear? So this is a classical case of iron deficiency anemia. And what will happen to the iron storage? Decreased serum ferritin. Clear? So these ferritin is actually the storage form of iron. So one can see low iron in the body, one can see decreased serum ferritin in the body, and this is a classical picture of which condition? Iron deficiency anemia. Very good, Priya, right? So based on the option you can mark your answer. So this is a classical case of iron deficiency anemia, and every year we have a question from anemia topic as such. Next question. 25 years old male presents with fever, chills and malaise and is diagnosed with malaria caused by Plasmodium vivax. He has a history of hemolytic anemia among males in his family. Before initiating anti-malarial treatment, which enzyme level should be checked to ensure the safety of anti-malarial therapy? Now here, if we just write the keywords, now this is a known case of, very good Priya, very good. So this is a known case of Plasmodium vivax malaria. Clear? That's a known case. So having fever, chills, malaise, rigors and all. Now what is more important here, there is history of hemolytic anemia in family. Okay, that's number 2. Now we want to start anti-malarial treatment, and most likely in this particular case the question is about using primaquine, which is used for radical cure of malaria, right? So with respect to this question, the question is most likely to be talking about primaquine. Now primaquine has a tendency of causing hemolytic anemia, especially in a fellow who is having deficiency of one enzyme, that is glucose 6 phosphate dehydrogenase. That's very important to remember, dehydrogenase, right? So the exact nomenclature is glucose 6 phosphate dehydrogenase. Now why I kept this question, glucose 6 phosphate dehydrogenase, because there is one more similar sounding enzyme, and that is glucose 6 phosphatase. Clear? So please make sure that you don't mix up between the two names. Glucose 6 phosphatase is a different enzyme in gluconeogenesis pathway, where glucose 6 phosphate is ultimately converted into glucose. So that's a separate thing. And this glucose 6 phosphate dehydrogenase, it protects RBCs from oxidative stress. Clear? It prevents RBCs from oxidative stress. So whenever this enzyme is deficient, and if the RBCs are subjected to oxidative stress, they burst out, and that what results in hemolysis. Clear? So if there is absence, it results in hemolysis. So the only purpose is to inform you that G6PD is different, G6P is different, right? So G6P is different and G6PD is different. So just make sure that you don't fall into this basic trap, okay? So this is how you should solve this question. Now moving forward to the next question, and here a patient presents to the neurology clinic with the complaints of difficulty in switching from one movement to another. He also reports having uncontrolled hand movements when trying to perform rapid alternating movements, particularly when asked to touch his nose with fingers. What is the most likely diagnosis? Now, this question is actually more of practical. Now, let us take the keywords first. So, what are the keywords which are given to us? One is difficulty in switching from one movement to other. Then second is uncontrolled hand movements. And third is difficulty in performing rapid alternating movements. Rapid alternating movements, especially when asked to touch his nose with finger. Now, what is the most likely diagnosis here? Now, in this question, if you look at this particular keyword, uncontrolled hand movements, uncontrolled hand movements, and this is particularly coming when the patient is trying to do rapid alternating movements. Now, this uncontrolled hand movements is known as tremors. So, what is this known as? Tremors. And when the tremors are coming, when patient is doing an activity, what are such type of tremors? These are known as intention tremors. Right? Intention means the patient is trying to do something, then only the tremors are coming. When he is sitting idly, no tremors. Now, there is one more condition in which we see resting tremors, in which the patient is having tremors even though he is not doing anything. Clear? He is not doing anything, sitting, but still the hands are shaking. So, this is known as resting tremor. and if the patient is doing something, then only the tremors are coming. It is known as intention tremors. Now, what are the conditions in which you will see intention tremor? What is the condition in which you will see resting tremors? I think for resting tremors, all of you must be knowing the answer. That's a separate entity. Now, so this question is basically based on intention tremors, because the patient is having uncontrolled hand movements as he is trying to do the finger nose test. So it is classically intention tremors. Now the resting tremors, they are seen in Parkinsonism. I think all of you must be knowing that. Resting tremors, bradykinesia, slowness of movement, then fascinating gait, all Parkinsonism. But that's not the condition in discussion for the time being. Intention tremors suggest cerebellar lesions. What is suggest? Cerebellar lesions. So it means there is some lesions of cerebellum. Now, what is the function of cerebellum? Coordination of movements. Right? Coordination of movements. So therefore, if there is cerebellar lesion, this is lost and the patient is not able to do rapid alternating movements, and this is known as dysdiadochokinesia, right? So dysdiadochokinesia. So just for the sake of remembering this word, I am using different colors. Dysdiadochokinesia. Okay. So if the patient is not able to do rapid alternating movements, this is known as dysdiadochokinesia, and this suggests lesions of cerebellum. And how we check dysdiadochokinesia? We tell the patient to do quick supination and pronation. That's the easiest way to check. Supination, pronation, like that. Although in this question it is finger nose test, we can also do heel shin test, but in this particular, but the classically which we prefer is supination, pronation. And if the patient is not able to do quick supination, pronation, we can think that there is some problem with cerebellum. So this is cerebellar lesion. So 2 points which you can understand in this question: intention tremors, dysdiadochokinesia. So for the time being, please remember this much, and this is how you will solve this particular question. Then moving forward to next question, a patient underwent cholecystectomy and black pigmented gallstones were found in gallbladder. Past medical history reveals the patient had multiple episodes of shortness of breath and chest pain, and this required hospitalization. What is the likely cause? Yes, so we can write the keywords first. Post-operative cholecystectomy means the gallbladder is surgically removed, and within the gallbladder what we can see? Black pigmented gallstones, right? So in the gallbladder. Then another is past medical history of what? Shortness of breath, that is dyspnea, chest pain, and because of this the patient has to be hospitalized. Now, what condition? Very good, Priya, very good, absolutely right. So this is sickle cell anemia. Now, pigmented gallstones. suggests that there is some hemolytic condition. Clear? So pigmented gallstone suggests that there is some hemolytic condition. So we have to think of some condition which is causing hemolysis, and this is part A of question, say this is part B. Now part B is actually telling us that what is that actual hemolytic condition. So now what you can see here, there is shortness of breath and there is chest pain. Now these two facts, this relates to vaso-occlusive crisis. Vaso-occlusive crisis of which condition? Sickle cell anemia. Because what happens, whenever there is low oxygen, what will happen? The HBS will polymerize and it will form sickle shaped RBCs, and these RBCs will cause vaso-occlusive crisis, right? So the classical answer is sickle cell anemia. So we can correlate hemolytic anemia part, we can correlate the hospitalization part that is happening because of the vaso-occlusive crisis, and vaso-occlusive crisis is related to sickle cell anemia, right? So Priya, you are absolutely right, but this is how we can correlate the answer with the stem of the question. The next question, a patient presents with unilateral throbbing headache associated with photophobia, nausea and vomiting. She reports that each episodes last for 24 hours maximum. What is the management of an acute episode? Now again, this is very classical topic. Always and always we have a question from this, either in medicine or pharmacology. So very good, Priya, you are absolutely right. So what we are getting here, unilateral means one-sided throbbing headache, like pulsating headache. There is photophobia, means sensitivity to light. So photophobia, sensitivity to light. Then obviously associated with nausea, vomiting. Clear? And most importantly, the duration is 24 hours. So this classically is suggestive of migraine. Clear? So this is classical of migraine, and acute case of migraine, especially moderate to severe episode. For acute cases, for treatment, what we need to give? We need to give sumatriptan, right? So this is how you will search your answer as sumatriptan. So very good, Priya, right? So this is classical case of migraine, moderate to severe episode, treatment is sumatriptan. And for prophylaxis, if we want to make sure that the patient is not having migraine attack, we can start the patient on propranolol, right? So for prophylaxis, we can start the patient on propranolol, non-selective beta blocker. Clear? So this is how you should answer this question. Treatment, sumatriptan, prophylaxis, propranolol. Very good, Priya, very good. The next question, a group of friends went to bar, had drinks and became intoxicated. Later they got into a fight and one of the fellow was punched on the chest. Later on, he presented with difficulty in breathing. On examination, breath sounds are absent on one side of the chest, and percussion shows hyperresonance. A chest X-ray reveals tracheal deviation to opposite side. What is the most likely diagnosis? Very good, Priya, very good. So just as a part of discussion, let us write the keywords first. There is trauma to chest, right, number one. Then difficulty in breathing, dyspnea, right. Then absent breath sounds. Importantly, hyper resonance on percussion, and chest X-ray tracheal deviation to opposite side. Clear? So this much we are getting, and yes, Priya, you are absolutely right. So this is the classical clue which will help you to answer this question. So the moment you have this hyper resonance, it suggests that there is pneumothorax, number one. So pneumothorax. It means there is air in the pleural cavity. So hyper resonance means pneumothorax. Now we have two options: traumatic pneumothorax, tension pneumothorax. So why we should choose only answer B, option number B, and not option A? So the clue is tracheal deviation. So this is suggesting that this condition is tension pneumothorax. Clear? So if there is tracheal deviation to the opposite side, you should choose the answer as tension pneumothorax. If there is no tracheal deviation, then you can go for traumatic pneumothorax, right? So this is very important clue for tension pneumothorax. Okay, obviously the breath sounds will be absent, so that's how you should go. So this is the classical clue to reach up to your answer: tracheal deviation to opposite side. The next question: a chronic alcoholic male presents in the emergency department with severe epigastric pain radiating to the back with nausea and vomiting. On examination, his abdomen is tender in the epigastric region and there is no palpable mass. Which is the most specific and reliable marker for diagnosing this case? Now again, we can write the keywords first. Chronic alcoholic. Very good, Priya. Then there is severe epigastric pain, and this pain is radiating to the back. Clear? So it is radiating to the back. Then tenderness in epigastrium, no palpable mass. So this is very suggestive of acute pancreatitis. So this is very suggestive of acute pancreatitis because most common cause of acute pancreatitis is alcoholism, right? So this is how you can associate this fact. And the classical presentation is epigastric pain going back or radiating back to the chest. That's the classical presentation. So this is the classical presentation of acute pancreatitis. Now which one we prefer? Obviously serum lipase. We will not prefer serum amylase because it can be related to other conditions also, but lipase is more sensitive and specific for pancreatic pathologies. So we'll go for serum lipase. Next question. A 45 years old male presents with right-sided facial weakness. On examination, there is absence of nasolabial fold on the right side. The patient can wrinkle his forehead on the right side, but his mouth had drooped to the right side with dribbling of saliva. Based on these findings, what is the type and location of the lesion? Now, to understand this, let us draw the face of the patient. Something like this. Okay. So say this is the right side of the patient, this is the left side of the patient. Now what is happening, if suppose this is the nose here, then this is the nasolabial fold, right? So there is no nasolabial fold on the right side. Then what about the mouth? The mouth is drooped to the right side. So the mouth is something like this. But what is happening? The patient can wrinkle the forehead on both the sides. So here are the eyes like this. So what is happening here? Absence of nasolabial folds, angle of mouth drooping to the right side, but the forehead is absolutely normal. So this suggests which type of paralysis? This is a classical case of upper motor neuron type of palsy. Now why this is upper motor neuron? So because some would say that the nasolabial fold is gone, the angle of mouth is drooping down. Why it is not lower motor neuron? So you need to remember a couple of things, like if I write upper motor neuron type palsy, lower motor neuron type of palsy. Now what is happening? The classical difference is you have to look for the wrinkling of forehead. It is present in upper motor neuron and it is absent in lower motor neuron. That's very important. Very good, Priya. So that's upper motor neuron. Now secondly and most importantly, so this we have already reached up to the answer that this is a case of upper motor neuron. That's we have discussed. Now location or side. Lower motor, same side lesion, but upper motor is opposite side. Clear? So in this case, what is the side involved? Left side upper motor neuron lesion, and the manifestations are on the right side. So is that clear? So here what we will write? Contralateral. And here it is ipsilateral, right? So that is how you should differentiate upper motor neuron facial nerve palsy or lower motor neuron facial nerve palsy. Clear? So facial palsy, upper motor neuron, facial palsy, lower motor neuron. And obviously what is, if you write structure affected in upper motor neuron, what is affected? It is the corticobulbar fibers, and here it is the facial nerve itself, right? So these are the three important differences which you should know. And how we will differentiate? The only thing, whether the patient is able to wrinkle the forehead or not. If there is no wrinkling of forehead, then most likely it is lower motor neuron. If the patient can wrinkle the forehead, then it is upper motor neuron, and the pathology is on the opposite side. Because the the forehead muscles, they have got bilateral cortical representation. So even if the one side is gone, the other side will manage. So that's why in upper motor neuron there is no problem with the forehead wrinkling. Okay, so this is how you should go. So the answer will come out to be upper motor neuron, left side, although the patient is presenting to us with right sided facial weakness. So the answer will be upper motor neuron, left side, because the forehead is all okay. Chalo. Next question. Alcoholic patient presents with palpitations, dizziness and syncopal attack. On examination, irregular pulse was felt. What will be seen on JVP? So again, firstly you have to make the diagnosis and then only you can correlate that clinical condition with the JVP findings. So let us write the keywords first. Palpitations means the patient is aware of his heartbeat. Dizziness, syncopal attacks means loss of consciousness attacks, and most importantly the pulse is irregular, right? So there is no specific order, right? So like this, irregular, no particular sequence. And now what is this condition? And this is a alcoholic patient. So firstly we have to diagnose the condition. The condition is atrial fibrillation. Okay, so what is the condition? Atrial fibrillation. And this is also known as holiday heart syndrome. In alcoholic atrial fibrillation, this is holiday heart syndrome actually. So alcoholic patient, they can develop atrial fibrillation, and one of the classical feature is irregular pulse. Now what is the JVP findings? Jugular venous pulse findings. Now in atrial fibrillation, if you know the basic pathology, the atria doesn't contract properly. This is the basic problem here. Now in JVP, A wave is because of atrial contraction. This is one fact. Okay, so A wave, atrial contraction. Now we know that in JVP, in atrial fibrillation, the atria is not contracting properly. So obviously it will be no A wave. So that's the classical correlation, and the answer will be absent A wave, right? So in a case of atrial fibrillation, there will be absent A wave because the atrium is not contracting properly. So that's how you will answer this question. Next question. A 25 years old female with previous history of rheumatic fever, examination shows loud S1 and mid diastolic murmur. What is the valvular heart disease? Now I think this is one of the most easiest question and also most important topic which we see in the exam. So let us write the keywords here. It's a known case of rheumatic fever. Now what she is having? She is having loud S1 and mid diastolic murmur, right? So these are the keywords which are given to you. Now loud S1, let us take this loud S1. Firstly we should know what is the reason for S1. Very good, Priya. So S1 is because of closure of AV valves, right? Mitral and tricuspid. And in cases of mitral stenosis, the mitral valve closes with a loud sound, and therefore a loud S1. So that's an important clue here. Loud S1 means mitral stenosis. Although the valve is getting stenosed, but still it produces a sound while closure. So loud S1. And mid diastolic murmur, that is between S2 and S1. So these are the two important conditions that suggest mitral stenosis. And more importantly, most of the cases of rheumatic fever, if they are not given secondary prophylaxis, they will ultimately develop mitral stenosis. Okay, so this is how you will remember this condition. Then there is an opening snap also. Clear? So OS, you can remember like this. Then chest X-ray findings are very importantly asked in exam. There is straightening of left heart border, then there is double atrial shadow, so these are few terms which you should know in relation to chest X-ray, and these are frequently asked in examination. So just two important key points: loud S1, mid diastolic murmur. The answer has to be mitral stenosis. Next question. A patient presents with weight gain, thinning of hair and dry skin. Diagnosis is Hashimoto's thyroiditis. What antibody will be seen in this case? So again, like if we just take the keywords, very good, Priya. So here the patient is having weight gain, then thinning of hair, dry skin. Now this all is suggestive of hypothyroidism. What is this? Hypothyroidism. And yes, this is a known case of Hashimoto's thyroiditis. And what happens here? This is an autoimmune condition resulting in, so this is autoimmune destruction of thyroid leading to hypothyroidism. Now what antibodies are present here? Anti-thyroid peroxidase antibody. So this is destruction because of anti-thyroid peroxidase. Clear? Anti-TPO. So this is TPO. So this is Hashimoto's thyroiditis. The patient is presenting as hypothyroidism, and classical picture is weight gain. Classical. Chalo, next question. A road traffic accident patient has received 4 units of packed RBCs within few hours. Which of the following will be seen? So again, keywords: known case of road traffic accident and 4 units of packed RBCs transfused quickly. Now what is this? This is known as massive blood transfusion. Clear? So this is what is known as the massive blood transfusion. Now what happens whenever we do massive blood transfusion, where large amount of blood is uh, transfused within a short period of time, there is accumulation of citrate. Accumulation of citrate. Now the question is, from where this citrate is coming? Now this citrate is actually the anticoagulant in stored blood. So the blood which we are storing, we add an anticoagulant, and that is citrate. And when we give blood transfusion, this citrate is metabolized by liver. But if you do massive blood transfusion, this is not adequately metabolized, because we are giving too much of workload to the liver, so it cannot metabolize all the citrate. So if the citrate is unmetabolized, it has a tendency to bind with calcium. So what will happen? The calcium, the free calcium will bind to citrate, and therefore the one which is present in the blood will fall down, because much of the calcium will bind to citrate. So what will happen? The serum calcium level will fall, and therefore the answer will be hypocalcemia. So in massive blood transfusion, this is the reason why we see hypocalcemia. So next question. A young female patient presents with ptosis showing diurnal variation. CT chest shows anterior mediastinal mass, which is a thymus gland cancer. Which receptor is affected in this patient? Now I think the moment you go with the question stem, you must have reached up to your diagnosis of the clinical condition given here. Yes, Priya, absolutely right. So let us take the keywords first. Young female, right? Then ptosis. The moment you have ptosis in question statement, always think of one condition. So ptosis, and it is showing diurnal variation. Now ptosis means drooping of upper eyelid, and diurnal variation means changes during 24-hour cycle. Sometimes it is more, sometimes it is less, so that changes. Then there is thymus gland cancer. This is classically thymoma. So the moment you have this kind of presentation, the diagnosis is myasthenia gravis. So it is myasthenia gravis. Okay. So this is myasthenia gravis classically. The moment you have ptosis, which is more towards the end of the day, thymoma, go for myasthenia gravis. Now what is the pathology in myasthenia gravis? In myasthenia gravis, there is antibody mediated destruction of the post synaptic acetylcholine nicotinic receptors. So the pathology is antibody mediated destruction of post synaptic acetylcholine nicotinic receptors. Okay, that you should know. So that's very important. And here the only thing is more during evening or repetitive use. So that's for myasthenia gravis. Again, a very important topic from exam point of view. The next question: a patient presents with palpitations, headache, sweating, blood pressure is 180 by 100 millimeter of mercury, 24 hours urinary metanephrine values are elevated. What is the diagnosis? I think it's again very basic question, and it has been repeated many number of times. So if we go with the keywords, so what is happening here? Palpitations, headache and sweating, along with hypertension. Very good, very good. So the moment we have these three words, this is the classical triad of pheochromocytoma. Clear? This is the classical triad of pheochromocytoma. Now, what is happening? There is increased release of epinephrine and norepinephrine. Epinephrine and norepinephrine, which are the catecholamines. Now, they are metabolized and they produce metanephrines or normetanephrines. Clear? So this is after metabolism. Now these can be increased in blood or urine. So if there is high metanephrine levels, so increased 24 hours urinary metanephrine. So that is again indicative of pheochromocytoma. So that's the classical presentation of pheochromocytoma. So I think most of you can answer it nicely. Next question: a known case of hyperthyroidism who is not on medication is scheduled for total thyroidectomy. Pre-anesthetic checkup was not done properly. Now, what is the leading complication that can occur during surgery? Now here, let us take the keywords. Patient is a known case of hyperthyroidism, right? Overactivity of thyroid gland, and is taken for thyroid gland removal, that is thyroidectomy. And what mistake has been done? Without controlling overactivity of thyroid, right? So very good, very good. So overactivity of thyroid is not controlled and the patient is taken for surgery. So what will happen during surgery? There will be release of thyroid hormones or the stress of perioperative period. So that will result in thyroid storm. So what is the condition? Thyroid storm. And what will happen? This increased thyroid hormone, they will sensitize the heart to effects of catecholamines, right? And because of this, what will happen? Tachyarrhythmias. So there will be arrhythmia. So if the patient is not controlled and is taken for surgery directly, there will be thyroid storm in the intraoperative state and the patient can go into arrhythmia. So that's very important, that always and always control the status by either propylthiouracil or methimazole. then only take for surgery, right? So don't take the patient for surgery in hyperthyroid state, otherwise arrhythmia is bound to occur. Clear? So that's one of the most fatal complication which can occur during surgery. Chalo, next question. A patient presents with hypertension, hypokalemia and metabolic alkalosis. CT scan shows mass over the right kidney with elevated aldosterone to renin ratio. What is the next best step for management of this patient? Now, much of the clue has been already given that what is the case. So let us write the keywords first. Hypertension. Then second is hypokalemia. Then metabolic alkalosis. Then CT scan is giving us clue that there is mass over right kidney. Now this is important, mass over, not within the kidney, it's the mass over right kidney, and increased aldosterone to renin ratio. Now, what is this condition which you think? Now, if we go with the clues, number one, mass over right kidney, as what the CT scan is suggesting us, and it means there is some adrenal pathology, because adrenal gland is what is suprarenal gland. So it means there is some problem related to adrenal gland. Now we know that from adrenal gland many hormones they come from cortex, catecholamines come from medulla. So how to check that what is the actual site of pathology? So if you go with this point, you can see that there is more secretion of aldosterone. That's why the ratio of aldosterone to renin is high. And we know that what is the effect of aldosterone? It preserves sodium and it excretes potassium. That is what is the effect of aldosterone. And sodium is related to blood pressure. So that's what is written here. The potassium is going down, resulting in hypokalemia. Sodium is more, and that what is resulting in hypertension. So it means what is happening here? There is excessive secretion of aldosterone. This is one fact. Now, aldosterone secretion, increased aldosterone secretion, how it can happen? It suggests that there is some tumor, so there is some adenoma which is secreting the aldosterone, so adrenal adenoma. And this, if it is on the only on one side, like this, if it is on the one side, what we can do? We can remove it. So remove if unilateral, don't remove in case of bilateral. So it is adenoma, and this condition is actually known as Conn's syndrome. Clear? So this is Conn's syndrome, aldosterone secreting adenoma. So in such cases, if it is only on the one side, we can go for removal of the adrenal gland. So this is only if the pathology is unilateral. I am repeating again. For bilateral, we need to give some drug on lifelong basis, and obviously if you look at the option, you will get the answer. So for bilateral, we need to give spironolactone, which is aldosterone antagonist, right? So for bilateral, go for drug therapy, but unilateral, you can remove one side removal, that's not problem. Yes, Priya, you are absolutely right, that Conn's syndrome. So for unilateral side, you can do surgery and you can remove the affected adrenal gland. So this is a classical presentation of Conn's syndrome, where there is excess of sodium, loss of potassium, and this is what is resulting in alkalosis also. Clear? So please remember this. Now next question. A young male has following serological status: hepatitis B surface antigen positive, IgM anti HBC negative, but IgG anti hepatitis B core positive, hepatitis B envelope antigen positive. Now what is the best treatment for this patient? So let us take the markers first. Hepatitis B surface antigen is positive. It means there is current hepatitis B surface, hepatitis B viral infection, right? It's going on. Now IgM anti hepatitis B core, this is negative. It means it is not recent infection. IgM is for recent. The next is IgG anti hepatitis B core, this is positive. So it means there is chronic infection. Okay, so it's a chronic infection. And lastly, hepatitis B envelope antigen is positive. It means the patient is highly infectious. Clear? So this is how you will take the markers with you and you will understand what is happening. So the given case, if we go with the diagnosis, it is a chronic hepatitis B virus infection with high infectivity. Clear? So this is how you will make the diagnosis. And yes, for chronic hepatitis we can give lamivudine. Okay, so this is how you will approach such questions, which are very common in papers. Then the last question: a 6 years old child presents with recurrent pneumonia, steatorrhea, and failure to gain weight. Which of the following is most confirmatory diagnostic test? So again, you have to evaluate the keywords first. You have to make a clinical diagnosis, then only you can answer which test will be best for this condition. So here, 6 years old child, recurrent pneumonia, steatorrhea, then failure to gain weight. Now here the classical clue is steatorrhea. Now what is steatorrhea? Steatorrhea means fat in stools. So the fats are coming. Yes, Priya, you're absolutely right. So it means the fat is coming in the stool, and it means there is fat malabsorption. The fats are not absorbed from the gut. Now, which is responsible for fat absorption? It is actually exocrine pancreas. So right, so it means there is some insufficiency of exocrine pancreas, therefore the fat is not absorbed and therefore it is coming in stool. So one thing is insufficiency of exocrine part of pancreas. Number two, the patient is having recurrent pneumonia. Now what is the reason for this? This is because of thick mucus, right? That's why the patient is having lung infections again and again. And because of this malabsorption, the patient is not gaining weight. So this is how you will understand the spectrum of the condition, and this condition is cystic fibrosis, where the secretions are thick. So here also the secretions are thick. Clear? So the classical pathology is thick secretions. Therefore the child is having recurrent pneumonia, he is having steatorrhea, right? So this is cystic fibrosis. And for cystic fibrosis, we can go for estimation of sweat chloride, right? So this is how you should approach this kind of question. So I think we have covered very good number of topics, and I'm very sure you must have enjoyed the session. Keep on studying. God bless. Bye bye.